So I'll just start by presenting who I am, and then we'll start with some of the housekeeping elements. My name is Gabrielle Altit. I'm a neonatologist based in Montreal, the Montreal Children's Hospital. I'm one of the co-chair for the Neonatal Hemodynamics Research Center Targeted Neonatal Echo NP Foundation curriculum. And I have the pleasure to do this with my colleague, Dr. Amy Stanford, who's based at Iowa. Today we will have the pleasure to have a great friend, colleague, and expert in neonatal hemodynamics, as well as neonatal POCUS, which is Dr. Jessica Lauren Ruoss, who is a neonatologist and associate medical director of the NICU at Winnie Palmer Orlando Health Regional Hospital Pediatrics. She has a clinical and research interest in neonatal hemodynamics and point-of-care ultrasound for the rapid assessment and management of neonatal hemodynamics disturbances. Lauren has done a lot of training. One of her training was through the Neonatal Hemodynamics Fellowship Program at Iowa. And she's been the lead at her institution for both hemodynamics and POCUS for a few years now. Before we get a chance to hear Dr. Ruoss for this session, I want to remind everyone that we will have a first webinar that's going to be a bit more didactic, and then after that, we'll have a closed session for our panelists to engage with Dr. Ruoss on a case-based presentation discussion, and that will be on a separate Zoom link that will be provided into the chat by Laura Thomas. And so I do want to also take the little minute to thank Laura Thomas and Megan Hudak, who are in the background working very hard to make this series a frank success. So a huge thanks to them for that. Other few housekeeping elements. So this session is supported via an unrestricted grant by Mallinckrodt in terms of an unrestricted educational grant. And so we're very grateful for this, to supporting for this activity. Also, this session is accredited by the Royal College of Physicians and Surgeons of Canada via the Section 1s for Maintenance of Certification Program. And then I do want to remind you all about the Dr. Reagan Gissinger Clinical Cardiopulmonary Physiology course, which will take place in November. You have here the QR code, and the web link will be provided in the chat. This is really a fantastic conference that is virtual and really brings together some of the big researchers, experts in neonatal hemodynamics, and provides a fantastic opportunity to learn on the topic. So I highly encourage you to register for this session. And then finally, I do want to mention that we're going to have a survey link in order to provide us some feedback, and that will be provided very soon through the chat to all our audience. So on this note, I'm going to be very happy to have Dr. Ruoss take over. And thank you so much, Dr. Ruoss, for giving your time, expertise, experience on the topic, and I'm sure our audience will greatly benefit from this. So the microphone is yours. And we see your slides.
Can you see them now?
We see the slide, but we don't see it in presentation mode. We see it in presenter mode right now. So you would need to go to display settings on top left and then change. Oh, there you go. No, we see PowerPoint.
Hold on 1 second. I will fix it.
The joy of PowerPoint.
Yes.
They can make a little master's degree on learning how to use it.
Set screen 2. There you go. Now let me know if this works. Yes?
Yes, perfect. Thank you so much.
Yeah, no, thank you. Well, thank you, Gabriel, for that kind introduction, and Laura and Megan for inviting me and helping me throughout this process. And of course, to my good friend, Amy Stanford, who is another one of the co-leads for this course. Very excited to put this together. I always learn something new whenever I put together a talk. And so excited to do just the 30-minute didactics and then, of course, go through some cases with you all. So really one of the main things that I want to do today is go over some core principles that were really important for me to learn when I was out of training as a attending neonatologist and actually went back to Iowa to learn more about neonatal hemodynamics. And I think it's something that at least, I guess, over a decade ago now, really was not focused on a lot in neonatal fellowship training. And so I'm very thankful that it's now something that we talk about a lot and invite our trainees to learn about. So you're going to recognize the challenges with blood pressure interpretation. We're going to go through just some basic physiology on cardiac output and oxygen delivery, and then talk about different classifications of neonatal shock and how you can kind of use that knowledge to target your therapies to overall improve perfusion. So I put together this talk with actually a lot of different collaborations from people, which is what I do for a lot of my talks. This is from the amazing Pearl, where she said, "What do you think could be the clinical indicators of cardiovascular health?" And here are all of the pieces of the puzzle that can go together. And one of the ones that I think we focused a lot on over a decade ago was just blood pressure. That really was the target of, as long as you got a normal blood pressure, you were fine, you could go to bed, you don't need to worry about anything. And we've since learned a lot that that is really not a good indicator by itself. So as always, I love cases. So we'll do some cases during the talk and then of course have some cases after. So this is a 22-week gestation infant, 400 grams on a jet, on about 80% oxygen, has a UAC, has a normal mean arterial blood pressure, but a pretty narrow pulse pressure with 38/28. And you got a hemodynamics consult. And the TN echo shows a right to left PDA, just a completely depressed LV function, low RV, as well as LV cardiac output. And this is actually a case of a baby that is a real case from Iowa. That was my first time going up to visit, where I got to hang out with the amazing Reagan and try to learn, is this something that I want to learn more about? And it was this case that really taught me that there's so much that I need to know and so much that I was actually doing wrong. That I need to go and learn more. And so what do I mean by that? I was definitely trained to look at the mean arterial blood pressure. So in a baby in my unit, I would have at the time saw the mean blood pressure and said, oh, the heart's probably fine. There's really no reason to get an echo, and we shouldn't really get an echo in a 22-weeker anyways. And I could have completely missed this type of heart. So this is now kind of a combo of cases. This is a slide from Dr. Bischoff. And in this baby, you have a very low ejection fraction. So even though your blood pressure is quote unquote normal from a mean arterial pressure standpoint, you really have a baby that's poorly perfused in a low cardiac output state, and again has a LV that is completely dysfunctional. And so it's important to know that blood pressure alone does not tell the whole story. And it's really important when we're talking about shock to have an understanding that shock is looking at the perfusion of the tissues themselves. So there is a really good article from 2018 from Debut et al. That looks at utilization of functional echo to evaluate neonatal shock. And I will say, while the paper itself is really great, there is still a heavy reliance on looking at blood pressure and, of course, looking at lots of other markers. But I do highlight this to say, even as far as 7 years ago, we still were depending a lot on blood pressure. The Surviving Sepsis campaign 7 years ago still was depending a lot on blood pressure. And I'm thankful to say that we really are moving away from blood pressure alone. We're not forgetting its existence. We're not ignoring the numbers, but just not depending on it so much. And what I want us to focus more on is actual cardiac output and then the perfusion of the tissues. And we're going to talk more about what goes into that in the next couple of slides. So here's just a quick teaser of what we use in our unit for what is a normative blood pressure, and trying to get people used to looking at systolic and diastolic. And I will tell you, it is a change for us too. We are so used to looking at the mean arterial pressure and so used to looking at gestational age equals the appropriate blood pressure that you should target. And so while I say this, I'm not coming from a position of we've been doing this for years and we absolutely have it right, but coming from a position of we're also learning, we're also adapting in our unit and learning how to kind of tease these things out together. And we'll talk more about this in future slides. So again, another slide from a colleague that I just thought was a great representation, that a normal blood pressure is not a surrogate for normal perfusion. You could have a low blood pressure and be totally fine. Actually, your heart looks great, your perfusion's great, or you could have a low blood pressure and be very, very sad, as demonstrated by this very nice emoji. And then it really goes like that for normal blood pressures, high blood pressures, or low blood pressures. You just really don't know by blood pressure alone. So now to the physiology review. So as a reminder, shock is a state of impaired cellular injury. So it happens when the tissue oxygen delivery no longer satisfies tissue oxygen demand. And so you can go from a state of compensated shock to a state of uncompensated shock, where you're actually starting to have cellular injury and cellular death. And that's really the guiding principle of how we try to manage shock. So, determinants of cardiopulmonary hemodynamics, it's really based a lot on loading conditions. And I do feel very bad for the amazing people at Iowa, because it took me a very long time to get this now seemingly basic concept in my mind that it's all about loading conditions. Whether you're talking about the right side of the heart or the left side of the heart, it's about preload, it's about afterload, you're talking about contractility, you're adding in the heart rate. I had never heard of force frequency relationship or the stress velocity relationship before going to Iowa. So if this is new to any of you, please do not feel bad about it. It's a learning experience for everyone. And what you're trying to understand here is if you can have an understanding of what is causing the issue in the shock, then you can have an understanding of what is the next step that you need to do to improve tissue perfusion. And let's go through that a little bit more. So there are a couple of determinants of cellular homeostasis. And really what this is you're trying to determine your oxygen delivery and your oxygen consumption. And that's really the basis of your cellular metabolism and what we're trying to achieve in homeostasis to treat infants that are in shock. And so you have your cardiac output, which is stroke volume times heart rate. You have your blood oxygen delivery, which is a combination of your oxygen saturation as well as your hemoglobin. You have your O2 consumption. So we're talking about work here. So anything that increases metabolic demand, fevers, seizures, babies that need to be more sedated. Sometimes making babies a little bit colder will decrease their oxygen consumption. And then cardiac output is really this combination of preload, afterload, contractility, and heart rate, and it all ties in together. And the more you look at these slides, the more you read about this content, the more you apply it at the bedside, the better this will come into play in your own mind. So how do we improve perfusion? You improve it by increasing oxygen delivery and by decreasing oxygen consumption. And so you increase your FiO2, you increase your hemoglobin, you try to decrease your work. And so you make sure, again, that you're well sedated, that you're not febrile, that there's no seizures, that there's nothing that could be increasing that metabolic demand. And then you focus on cardiac output. And how do you do that? Well, in my institution, and now after learning about this, I use a lot of echocardiogram markers to try to have a better understanding of, am I dealing with a cardiac myocardium issue? Am I dealing with a preload or an afterload issue? Am I dealing with a baby that's heart rate is just really too high for the baby? What exactly is happening? And then, of course, the most important thing is after you do an intervention to reassess. So I know that we're talking about shock, and we're definitely going to get into the different types of neonatal shock, but I also think it's really important to go back to the basics and talk about the Frank Starling curve. And I can tell you that if you ever have the joyous experience of going to Iowa, you will get to draw these on the whiteboard and try to remember exactly what all of these are. And so I think it's important, though, to go through that process, because it's important to know that there is a difference between adults, there's a difference between neonates, and there's also a difference between a term neonate and a premature neonate. And I think that this slide really highlights that. And that's why when you look at the Surviving Sepsis campaign, for instance, and they recommend 60 per kilo of volume in an adult, you'll see now that it's more tailored in the neonate to give a little bit less volume. And you're going to need to tailor that even more in the premature infant. And this in part is based on the heart's actual ability to be able to handle that preload. So there is a point in the neonate where the myocardium gets so stretched that your myofibrils reach an optimal point that if you stretch them even further, they're actually not going to contract. So there is a point that giving volume is just not going to help with your stroke volume, as you can see in this picture. And in fact, in the premature infant, giving more volume may increase your left atrial filling pressure and may also increase it to the point where you have increased pulmonary venous capillary wedge pressure, which is a completely different talk. But just to say that we have to be cautious with volume administration, especially when we're talking about our 22 to 25 week gestation infants, because as you see by this, it's just not the same impact when you give volume in a fetus, a preterm, a neonate versus an adult. So there are other ways, though, to augment cardiac output. One way is through stress velocity. And what you're looking at here is changing your afterload to improve your stroke volume. You can change your afterload for the RV, which would be your PVR, or you can change the afterload for the LV, which would be your SVR. And there's different medications and drugs that we will go through that can help you change those loading conditions and impact your stress velocity. The next piece is force frequency. I remember, again, over a decade ago, being told by a cardiologist actually that we want the heart rate to be really high in this baby with acute pulmonary hypertension, because we know that cardiac output equals stroke volume times heart rate. And yes, that is the equation, but it's the force frequency relationship that tells us that there is a point, especially in a neonate, that when you increase the heart rate, you actually reach a threshold where you start decreasing filling or preload and end up decreasing your stroke volume. So it's not just a neutral sum game that you just push the heart rate up and you're going to make that cardiac output better, because we all know that that's the equation. You have to understand the force frequency relationship too. And that's why these charts, while anxiety provoking to draw them on a whiteboard, are so important to know and to understand. So I always like to learn things in multiple different ways. And so just want to put this out in a different kind of graphical representation, of course, made by the amazing and wonderful late Reagan Giesinger. So when you're talking about increasing LV afterload, those are things like removing the placenta, closing the PDA, having cold septic shock. That's something that we can also see in babies with critical coarc. So if you have a cardiogenic shock or a septic shock, it may present that way. LV function, again, myocardial ischemia, sepsis, you're looking again at your cardiogenic shock and your septic shock. Decreased LA preload, so anything that is going to decrease volume going into the left heart. So this could be obstructive neonatal shock. This could be hypovolemic shock. You could see this with severe pulmonary hypertension, which also may represent cardiogenic shock of the right side. So moving on to the right side, significant increase in RV afterload. So acute pulmonary hypertension, excessive mean airway pressure, which we will talk about later, can also act like a form of obstructive neonatal shock and cardiogenic shock. RV dysfunction, you have your myocardial ischemia, cardiomyopathies, you can have obstructive pulmonary vein disease. all of those things can present either as a form of cardiogenic shock, septic shock. We see this, unfortunately, in infants with severe HIE, which Dr. Gissinger had done a lot of work on and provided a lot of information for us. And then lastly, decreasing preload to the right atrium. So hypovolemia, positive pressure ventilation, and again, some form of obstructive neonatal shock. And the reason that I put this up here is to really highlight that the loading conditions with the preload and the afterload and the contractility, those are all things that we need to pay attention to when we're thinking about underlying physiology as the mechanism of different neonatal shock. So now that we're all experts, and I'm sure this was a review for everyone on neonatal shock physiology, let's move on to classification. So there's a couple of main types of classifications of neonatal shock, and it's a bit challenging because in our neonates, a lot of these are a little bit of a mixed representation. So we have our hypovolemic shock. Those are the babies who are in hemorrhage or capillary leak. Capillary leak, though, we also see with our distributive shock patients with warm shock, sepsis, inflammation. You have cardiogenic shock, which may have started from different things and then ultimately leads to a point of cardiogenic shock. But really, we're talking here about your primary myocardial dysfunction. So babies with myocarditis, babies with an ischemic hit to the myocardium, and of course, your congenital heart disease. Distributive shock, this is really your babies with vasodilatory sepsis is a lot of what we're thinking about here. You can also see this in babies with pulmonary hemorrhage, that they're having a distribution of blood flow into a container that it's not supposed to be. So whether that's going to be in the vascular bed or in the chest. And then obstructive. So obstructive, we commonly think of this as cardiac tamponade and pneumothorax. However, I urge everyone to keep on their differential too high of a mean area pressure, because if we have too high of a mean area pressure, we can actually cause a type of neonatal obstructive shock. And there's different hallmarks to the echo findings when we look at these babies. You can have a very hyperdynamic and small ventricle with hypovolemic. We have more high output cardiac failure and distributive shock. Obstructive, you actually have very underfilled ventricles, but you'll commonly see a very dilated IVC, meaning that it's not that the babies totally deplete of blood, it's just that blood can't get into the heart for some reason. And knowing that there's these different types of shocks, recognizing that they can also change, meaning you can go from hypovolemic, you can go from a cold septic shock to a distributive warm septic shock, and being cognizant of that and recognizing it and then being okay with changing your management is really important. And that serial assessment, again, is the hallmark of what we do in neonatal hemodynamics. So cardiogenic shock. You're really trying to, when you're talking about management, trying to define the primary ventricle. So here is a parasternal long axis view of an infant with a normal biventricular function. And then here is a baby with just a ballooned out RV at the top of the screen here, and a collapsed left ventricular outflow tract. And then next you have that picture as courtesy from Dr. Shazia Bumble of an LV that's just dilated and barely functioning. Identifying the primary dysfunctional ventricle will actually help guide your management because you're trying to figure out what loading conditions to what ventricle do I need to try to target. So here's a baby with a dilated RV that's compressing on the LV. I like to think of these RVs almost like a Pac-Man where they're trying to eat the LV. And what you're trying to do here is change the loading conditions to that RV in order to decrease the pressure and hopefully not hurt the LV anymore. So the RV, if it's dilated, it's maladaptive. That's a whole nother talk that we could go into. Through different types of interactions, the right ventricle can impact the left ventricle. And also of note, the right ventricle does tend to recover after the left ventricle, especially if the RV is your primary dysfunctional ventricle. Another way to look at this is that RV dysfunction and LV dysfunction, they actually can play on one another. So in the first picture, you have a normal short axis view with the RV on the top and the LV and a nice round LV. In the middle picture, you have an RV that's starting to push on the LV. And then to the right of the screen, you see the severe form where the RV is really ballooned out. It almost looks like the little mushroom man that you can see in Mario Kart racing. And this is where I feel like the RV is trying to literally eat the LV. And now you're starting to stretch the myocardial fibrils of the LV. You're decreasing filling of the LV. So you have LV dysfunction or decreased preload. You have LV dysfunction because it changes the shape of the LV, and you have LV dysfunction likely because it actually changes the myofibrils and stretches them. And so when you see a baby with biventricular dysfunction, it's really important to try to figure out which ventricle is the primary culprit. And I love this saying that a bad neighbor brings down the neighborhood, because I think that's truly true when we're talking about the RV, the LV, and the lungs. So physiology-based management. There's different medications that we can use that have different physiologic properties. It's also important to note that not all babies are the same. Not all babies' receptors are the same. Not all babies are going to respond the same. And we don't know a ton about receptor pharmacology down to that 22-week gestation. But just as a general overview, you have an inotrope, which is talking about your squeeze. You have a chronotrope, which is going to increase your heart rate. You have a vasopressor, which is more your vascular tone. You have a vasodilator, again, vascular tone, and then a lusitrope. That's looking at relaxation of the ventricles themselves. And why this is so challenging is that all of the medications that we use, they tend to cover multiple different receptors. And so they're very rarely a pure inotrope or a pure chronotrope. So I promised that we would go back to blood pressure. The reason I'm spending so much time on this is because it's something that we've been noticing in our own unit as something to really discuss and try to focus on. And that is, we do not have a 24/7 echo service for hemodynamics. We, of course, can get an echo stat in the middle of the night for an emergency, but it is not our standard to get an echo prior to starting cardiogenic meds, just based on the fact that we don't have the resources to wait on that. If somebody's here and can do the echo, great, but we have to have some way within our unit, and I'm assuming in a lot of units, to figure out what to do when you don't have an echo that kind of shows you the pictures. And so we're spending a lot of time looking at your systolic and your diastolic blood pressure. So low systolic blood pressure, think about decreased contractility, decreased LV preload, increased LV afterload. We're noticing babies with a really narrow pulse pressure that when we actually do get to put a probe on the chest, finding out that LV is usually down in those babies. When we're thinking about this, we're trying to decrease the afterload to the baby. And so usually we'll do dobutamine if they have an okay blood pressure. If they already have a low systolic blood pressure, then our first line is typically low dose epi. Low-dose epi should improve contractility. What we don't know is that it really should decrease afterload based on its beta receptor, but in different babies, it may not act exactly the way that you want. And you also need to look at your ventilator mechanics, because this could be decreasing preload to the left heart as to why the systolic blood pressure is low. So systolic blood pressure being low, you need to think about cardiac output. So again, just another graphical representation of how to think about this. And this is a slide courtesy of Pearl. And when you're doing this, you're either going to have decreased preload, so it's your Frank-Starling mechanism. You can have decreased contractility. You can have increased afterload through your force velocity relationship, and you have a low cardiac output. And this slide, which I'm happy to share with everybody, just goes through different causes of why you would see low cardiac output. Now, moving on to low diastolic arterial pressure. These are the babies that you really need to worry about. Do they have a massive PDA? So they're filling blood into a space that it's not supposed to be in, aka the lungs, or do they have systemic vasodilation as seen in warm shock, where they're having blood go into the venous or vascular space where it's not supposed to be? And so management here, you're thinking your volume resuscitation, vasopressors like vasopressin. We use norepinephrine a fair amount in our unit, especially in the tiny baby. And then we tend to do earlier hydrocortisone. When you're thinking about the PDA, you have maybe a low diastolic blood pressure, some mild organ dysfunction. We'll do some shunt mitigation strategies until we can get an echo. If it's severe, things that you could consider doing are dobuta, although admittedly in our unit, we're still more on the epinephrine or norepinephrine, depending on if it's systolic or diastolic hypotension. And these are just pictures of the PDA. That's all left to right. This is a picture of a baby with holodiastolic reversal of flow in the descending aorta, which is why with the PDA, you get that low diastolic blood pressure. And again, when you're thinking about diastolic blood pressure, you need to think about your vasomotor tone and you need to think about volume. So there's something going on that's causing vasodilation. There is something that has caused enlargement of a vascular bed. Another representation of this is trying to figure out in a child with low cardiac output and shock and or cardiogenic shock, meaning RV or LV dysfunction, what are some steps that you can do? This is really for when you have the ability to do an echo. You want to see, do you have a PDA? Is it closed or restrictive? And then now you're trying to figure out which ventricle is it? Is it the RV? If so, are you already on INO? If not, please start it. Is the baby hypotensive? If not, then we would do epinephrine versus milrinone. We would try to start milrinone if the baby has a higher blood pressure. If the baby is hypotensive and you're dealing with RV dysfunction, then we typically would have the babies on vasopressin and low-dose epi. We do, again, in our tiny babies, typically do norepi. The reason we do that in our unit is we tend to, for a lot of the babies, have a lot of success with low-dose norepi and not have to worry so much about the salt. I know other units don't have as much salt issues, but we do flip to vasopressin if the norepinephrine isn't working. If you have LV dysfunction, if you're on nitric, please stop the nitric. Reason being that you are at risk of having pulmonary venous congestion and pulmonary venous hypertension. Once you're off your nitric, you can then work on other things. For us, if it's severe, we typically do epi. You can do dobuta, but I would say in our unit, kind of our go-to for LV dysfunction is low-dose epi. So again, just classifications of neonatal shock. You're looking at hypovolemic shock, so small chambers on echo, hyperdynamic, low filling pressures. You're going to do volume resuscitation. For cardiogenic shock, you're going to have more of these ballooned out dilated ventricles. You may just have a ventricle that really just has very little kinetic or movement of the wall or the septum. With those babies, again, it's typically low-dose epi. It's milrinone if you can have a good blood pressure, and we can talk more about that in the question and answer and case discussion. Distributive, this is the babies that typically have a low diastolic blood pressure. You may actually have normal contractility and high cardiac output. And in these babies, again, it's still volume resuscitation using a vasopressor like vasopressin versus something that's a vasopressor as well as an inotrope like norepi. And then an obstructive shock, these are the babies that you're thinking about cardiac tamponade, pneumothorax, and again, too high of a mean airway pressure. And what you need to be doing here is really trying to relieve the obstruction. I'm just putting this up because this is what our guideline is in our unit. And a huge thanks to Dr. Anderson, who's actually now our point of care ultrasound director, for helping us create this. Again, in our unit, while we do have a hemodynamics program, we are not a 24/7 service. And so we really want to make sure that everybody, whether it's day or night, has an understanding of what should they be thinking about when they have a baby who looks like they're hypotensive or they're concerned for shock. And then what are some things that you can do? And so we go through whether it's systolic blood pressure, diastolic blood pressure, a component of both. We go through possible causes, what are different first line treatment options. We do this for both the systolic and the diastolic. And then we talk about if it's a combination. And we do, again, use that table that looks at the percentiles. And we try to target at least higher than the third percentile. And then here's another part of our guideline that really goes through the different medications that we use, the different types of doses that we recommend, including some max dosing and then some guidance of how to titrate. And we've also now, to help further with this, have an order set so that everybody, when they click on neonatal shock or neonatal hypotension, it comes up with all of these different options. And I do urge everyone to have something similar to this in your institution, whether you have a true hemodynamics program or not, because I think it really helps everybody understand what you're dealing with, what you're thinking about. It helps educate at the bedside and helps you guide your management. And with that, I will end. A huge thanks to my wonderful children, both fur and non-fur babies, the amazing neonatology group at Orlando Health and pediatrics. I have a great collaboration with pediatric cardiology here, and just a huge list of people, both mentors, colleagues, friends, that have helped educate me and continue to support me. I could not do this without the division of neonatology division at the University of Iowa, who had to suffer through with me being up there on and off for 3 years to finish their 1-year fellowship. And then, of course, at the University of Florida. Thank you.
Dr. Ruoss, thank you so much for such a fantastic review. So what we're going to do, we're going to ask for the entire audience to now go into the Q&A box and then provide us with your questions, and we'll try to have at least 10 minutes of question moments with Dr. Ruoss. And then Dr. Ruoss, if you could stop sharing your screen. While people are sending in some of the questions in the Q&A box, a few things. I do want to say that Laura is going to post a survey link for our audience. So please take the time to provide us your feedback so that we're able to constantly adjust the content as well as the format of some of our sessions. There will be a separate survey link for our panelists and participants to the next session. So this is really for the entire audience. So please, please, please take that 130 seconds, because we do end up kind of going through every single evaluations to get brilliant ideas of how we can kind of continue to grow this format and this forum. The other thing I do want to remind everyone is if you were not here at the beginning, there is the Dr. Reagan Gissinger Cardiopulmonary Physiology of the Newborn that will take place in November. And so Laura has put the link into the chat. It occurs between November 3rd and 6th, and it will be covering a diverse series of topics from expert speakers, and highly encourage you to register to this wonderful event. So I don't see any yet Q&A question. So Dr. Ruoss, that was fantastic. I actually screenshotted some of the tools that you've produced for your institution, which are great. And I'm sure many of us listening in were taking in some of these pictures. I guess one of my questions, if we can start some of the discussion, I'd love to hear your thoughts about, once you've picked up some of these clinically significant findings at bedside in terms of phenotypes in your patient, because we know some of these babies can shift between phenotypes depending on kind of their evolution. Kind of wondering, what's your approach in terms of When will you be following? What are the things you're going to be following at the bedside? What for you would be triggers to go back and actually get more information to see if, kind of this phenotype has changed? If you can just enlighten us about your particular approach in your center, knowing that you don't have a full 24-hour service, what would be some of the triggers you provide your colleagues to say, you know what, if this happens, call me, and kind of a sense of like the trajectory once you've identified a certain global picture in your patient?
Yeah, so it's been a really fun process. Hopefully, my colleagues find it fun too, of just an evolution. I think my colleagues very similar to me. We kind of practiced you start a med and then you keep going up and then you add a med and you go up and then you add another med. And so I think, Gabriel, you've heard this before, but I used to think vasopressin killed babies because every baby I gave vasopressin to died. And turns out if you just give vasopressin as you're dying, it's not a miracle drug. It doesn't save you when you're on
Yeah.
everything else. And so one of the evolutions that I've seen, and it's really been a learning thing together in my unit, is having some cutoffs of once I get to X dose, should I be thinking of something else? And so I think we were going a little bit higher on different doses, and then we started to go a little bit lower, and then started to get a little bit lower. And now I'm noticing that we don't really get that high on doses anymore, whether we have an echo or not, before people are starting to ask the question of, am I on the right med? Is the right physiology? What else is happening? Let's get an x-ray, not just to look at the lungs, but and our tiny baby team has taught me a lot about this, about hyperexpansion and how quickly that can change. And so our flag and our unit is changing in the blood pressure, changing in the perfusion, changing in the oxygenation, changing in the urine output, and then going up on meds when you really don't feel like you should need to go up on meds anymore. There was just an echo that I looked at right before starting this case of a 25-weeker. They had gotten an echo. They had started some low-dose nitric. The baby got hypotensive, and so they stopped the nitric, and that didn't work. And so they were coming back to say, okay, now I've added this. Can you come and take a look at this baby? What do you think? Like, this is the systolic, this is the diastolic. What do you think we should do next? And so, of course, I'm going to go scan this kid after this talk. And so it's kind of things like that. It's just people, I think, recognizing, and this is what it's been so fun, we're all recognizing the subtle changes and what those subtle changes can mean.
Mm-hmm.
There was a period of time where we would see a narrow pulse pressure and a normal mean arterial pressure and say, well, it's probably fine, and maybe it's just the UAC is not working. And now we've had enough babies that's become a flag for us to scan or even do a cardiac focus, which I know is not the subject of this talk. Mm-hmm. But we have more people trained in cardiac focus now to maybe be able to put the probe on the chest and see if the LV is just moving or not moving. And so it's really an evolution together and recognizing that this just didn't work the way that I thought it was going to work. And so now I need to go back to the drawing board. And whether you have an echo to go back or not, they're still going back. I, of course, will put a probe on the chest, but that's because I no longer know how to practice without it. But I think most people, that's not how we practice. And so that's why we created that guideline, so that people don't have to rely so heavily on something that isn't, easily attainable, at least in our center. It's a very long-winded answer. Sorry.
Yeah, no, but it's a complicated question, and I often get it. And I love what you just said. It's a bit like a physical exam. It's like, oh, when do you repeat your physical? Well, if the patient status is either not evolving towards the direction you would like or is deteriorating, well, you have to go back at bedside, stay at bedside, reevaluate, see what's happening, and try to understand what's the physiology, what you have to address. It's not like, oh, I got it, and it's going to be like this for the next 15 years, So I love that you said, that dynamic and giving like kind of pearls. I see there's many questions, so we're going to try to tackle some of them in the next 5 minutes. So number one, let's do a little blitz. What are your thoughts about norepi and trying to lower your PVR? There's a few papers showing this, and I think the reference is some of the papers from the French group. Any experience with that? I know that.
Yeah. So I don't typically use it to lower. I will use it even if you have high PVR. So if you're a term infant with high PVR and pulmonary hypertension, then I'm probably going to put you on vaso. If you're a tiny baby in our unit with high PVR, pulmonary hypertension, we will commonly still start with norepi, just because we found in those babies, most of them actually tend to respond nicely to that. They don't tend to have their PVR get worse. There are certainly outliers, though. I think if you polled the group of people, you're probably going to hear different things. But I use norepi not because I think it's going to lower PVR, but I don't think it's going to increase it like Epi does. I do worry about it on 100%, just like with Satyan's work that he showed. So it makes me a little bit nervous.
Hmm.
But that's kind of our threshold. I'm not sure what yours is, Gabriel.
Yeah, more work I think to be done on that topic, and we've seen we have a similar approach to you. Like in the tiniest babies, if we have this physiology, we'll tend to use norepi, but then we'll switch to vasopressin if we see we don't get the expected response, and we've had good success with that. But there's many that do respond to norepi, and because we have a lot of experience with it, I think many of our colleagues. But I can see, you know, a trend towards like an increasing use of vaso to the point that I come to the bedside and I say there's severe LV dysfunction. They're like, oh, let's give vaso. And I'm like, no, let's use the ninotrope first. So there's definitely more confidence about using vaso in many of the units, I think, because of the literature coming out on the topic. But I think there's a lot of still research to be done. But, I agree with exactly what you said. Another very good, I find excellent question is that when you get these very tiny babies, less than
Mm-hmm.
25 weeks, and they're in the first 24, 48 hours of life, and they're doing their transition, minding their own business, you go see them, their BPs look terrible on the screen, but the baby is like peeing, normal lactate, normal gas, normal oxygen exchange, well perfused, good pulses, and then everyone wants to start a drug. What do? You can see
Yeah,
my
so I,
bias.
I've really gone on a pendulum of this, which just says how I'm learning and that we need more data and more studies about it. So I used to just start a drug based on the blood pressure. That's how I was trained. That's what I did. And then I stopped starting a drug because I learned we don't need to worry about the blood pressure. Now with doing more echoes, I will tell you a lot of the tinies, I don't know how they haven't fallen off the cliff yet, but they'll be peeing and they won't be acidotic, but their blood pressure won't be great. And I will scan them and their heart does not look good. And then I'll start a blood pressure med on that. And so it's a hard place to be. I will say that we would probably start a little low dose epi because we've now had a couple of kids who the team calls and says, hey, something just feels off. I mean, their blood pressure is awful, but the baby looks fine. Can you just take a quick peek and see what's going on with the heart? And sometimes I look at the heart and like the heart looks great. So like whatever this blood pressure is great for the baby. But sometimes I do look at the heart and like this, I don't know how this baby is.
Yeah, we had a bit of these cases. You put your probe and then there's like some cardiac dysfunction. We sometimes use a bit of dobu in these patients and then we see like great success, but I guess it's the same philosophy of like providing a bit of inotropy. Okay, then last question I guess we're gonna go for because I think we could go on and on talking about fluid replacements. What are your thoughts about the use of albumin, and what are your thoughts of should we be giving? I guess the question is if you have a patient with a history of acute fluid loss, so a bleed, problem with placenta delivery, previa, abruptio, and now the kid is hypotensive, and on your assessment, you think the primary etiology is preload related, how quickly in a tiny prem would you consider kind of refilling the patient? And is there a role for albumin at some point in some of these kids? Tough questions.
Yeah, yeah. It's another pendulum that I've been on. So I love managing the big term infant because I give them volume and I'll give them albumin, even though the data is not that great for it. Actually, the very septic, volume down, tiny baby is somewhat of a nightmare for me because I have given volume to those kids and increase their LA pressure and then seen them get a pulmonary hemorrhage and don't know if it's in part because I gave volume too quickly. And so now I will give volume, but I will give it I will give it based on a rate, based on how I see the impact to the heart and the lungs now. So this is an evolving thing for me just over the past 6 months that I've started to realize that I can use echo and lung ultrasound to kind of give me some information of where I'm at with giving volume in the tiny, somewhat going by adult data on how they use lung ultrasound and echo for volume guidance. And so I think I would like us to study this more and use it more in tinies, because I do think we have to be very judicious. There's certainly babies, though, that I think do not survive because we do not give them enough volume. And I think there's also certainly babies, especially in the tiny, that we volume resuscitate them too hard and end up causing other issues like pulmonary hemorrhage and IVH. And so they're probably the patient population that we need to be the most careful in, and probably the patient population that we should be using echo and lung ultrasound in. Oh, Gabriel, I can't hear you.
I was saying thank you so much, Dr. Ruoss, for going over all these very tough questions, but very good questions, and for the fantastic presentation. I'm going